Introduction. So I know I'm in the last session between you and lunch, and you're all probably all hungry. So I'll try to be brief and hopefully appetizing to you. So these guidelines are very important. I know it's difficult to read guidelines sometimes, but these are especially important because they're not written for cardiologists. They're actually written for everybody who deals with patients in the preoperative phase. And they're very detailed, and they cover every single question that you might have. So there's no way I can cover this in 15 minutes. This was presented in the ESC guidelines as a summary in 2 hours. So I'm going to give you just what you really need to know, and then you can go ahead and read about the rest of it. I have some disclosures that are not related to this talk. So what's the magnitude of the problem? About 5% of the world population yearly undergo surgery. So that's about 300 million patients. And from all these patients, 85% are non-cardiac surgery. So that's a huge number of patients going for surgery. And for those of you who see preoperative cases, you know that you as an internist will end up seeing all these patients. So they're going for surgery, but nonetheless, they want you to risk stratifying them before they go for surgery. So consider these 4 patients. So Mr. R is a 50-year-old, has no past medical history, and he's undergoing TURP. Mr. X, he's 70 years old. He has diabetes and hypertension, and he's undergoing a esophagectomy. Mr. Y, he's 55 years old, previous history of MI 4 years ago, and now he's undergoing hiatal hernia repair. And then you have Mr. Z, who's a 30-year-old morbidly obese patient who is undergoing bariatric surgery. All of these are going to come to you for preoperative assessment, going for different kinds of surgery with different kinds of risks, and you're supposed to decide what to do for them. You're supposed to decide which patient needs to see a cardiologist before the surgery or not. So how are you going to do that? You've seen this slide earlier. So there are many multiplying risk factors that leads to the patient's risk for surgery. Some are patient-related, so an instant, the patient's morbid conditions, presence of acute coronary syndrome before, or presence of thrombotic or bleeding risks, hemodynamic risk, and arrhythmic risk. And there is issues with hypotension, hypovolemia before the surgery. But there is also in the center of all of this, the surgical risk. And surgical risk drives everything. So it's related to the type of surgery. So this is usually where you should start. Of course, you start with a patient with history and physical examination, but it's important to know what type of surgery the patient is going for and to know what's the risk of that surgery, because that's going to drive what you're going to do next. So this is how you stratify the patient. You evaluate the patient's risk, and you evaluate the surgery risk. So if it's a low-risk patient going for a low-risk procedure, I don't think you see my cursor. Sorry. So if you're a low-risk patient going for a low-risk procedure, then you require some attention, but not a lot of attention. And then considering high-risk patients going for a high-risk procedure, this is someone who requires more attention. Okay, so how do you evaluate the patient risk? It's easy to say, evaluate the patient risk. What do I expect from you to do? So first of all, history and examination. That's very important. Dr. Abdallah talked about this before. You need to take a good history and examination. And I think in the medical field, we're starting to suffer a little bit in this area. We have lots of tests, lots of risk models, and lots of laboratory and investigations, but we forget the history. History is cornerstone. And then you can do a preoperative assessment, and you should do an assessment for cardiovascular risk factors. So for those of you who do preoperative risk, you always use a risk calculator, right? So these are some of the common risk calculators. Probably the most commonly used is the first one, which is revised cardiac index, because it's the oldest one and it's an easy one. And there is an online calculator. You just click these things in the history of ischemic heart disease, cardiovascular disease, heart failure, use of insulin, renal impairment, and the type of surgery. And it comes with an estimation of the patient risk. There are other risk calculators as well. So these guidelines do not recommend a certain risk calculator. You can choose whichever you want to use, but you need to use one. And the guideline as well tells you that these risk calculators will actually underestimate the risk. So they're part of your evaluation, but they don't drive what you're gonna do. What really drives what you're gonna do is your estimation of the patient risk and what type of surgery the patient goes for. So all these risk calculators have been validated in surgical literature with different risks associated with them. Use one of them, but as I said, really focus on the surgical risk. So this is the surgical risk. So for the guys who are taking pictures of the slides, this is important. Take this picture, keep it in your favorites on your phone, hang it in the preoperative clinic. You need to know which surgery is low risk, which surgery is intermediate risk, and which surgery is high risk. And for people who do preoperative assessment a lot, this is different than what the revised cardiac index say. So for example, for what revised cardiac index says is for all intraperitoneal surgeries are considered high risk. But if you look over here in the intermediate list, you will find intraperitoneal surgery. So it's the splenectomy, hiatal hernia repair, cholecystectomy. These are intermediate risk surgeries. Whereas other intraperitoneal surgeries like duodenal and pancreatic surgery or esophagectomy or liver resection are considered high risk. So keep this with you because then you're gonna have the flow chart. So what's very nice about these guidelines is there are flow charts for everything, really everything. And there is a flow chart for the assessment. So you start with, is this surgery urgent or emergent? So emergency surgery is a surgery that the patient will die if he didn't have it done at the moment. So if someone comes in with tamponade and he needs to go for surgery, nobody's gonna call you for that. It's insane if they call you. Or if someone has tension pneumothorax, for example, and he needs to go for surgery right now. If someone is at trauma and they're actively bleeding in their abdomen, they need to go for surgery right now. There is no way to do a preoperative assessment. What about urgent surgery? Urgent surgery is something that needs to be done. Probably is going to take an hour or two to happen. It's still something that the patient needs to go for surgery. There's no time to do assessment or cardiac testing or whatever, but it's a little different level of urgency. So if it is urgent or emergent, patient needs to go for surgery. What about if it is time-sensitive surgery? So time-sensitive surgery is a surgery that doesn't need to happen today, but if there is a delay in the surgery, it will affect the outcome of the patient. So that's generally surgeries that are done for cancer patients, because if you delay your surgery by the time you get the stress tests and the echo, then there might be dissemination of the cancer. Or like symptomatic carotid artery disease. They need to go for the surgery. If you delay it, they can develop stroke. So in time-sensitive surgeries, there is a little time to consider doing something, but you have to weigh it with the risk of delaying the surgery, and you have to base it on a case-by-case. Now, if it is truly elective, get a good history and clinical examination, including standard lab tests, and then you have to give them advice about stopping smoking. So they need to stop smoking 4 weeks before the surgery, and you need to optimize their medical therapy as much as you can. So if they have diabetes or hypertension, you need to optimize all these conditions. And then you stratify the patients according to age, risk factors. So if the patient is less than 65 years old and has no cardiovascular risk factor, if they're going for a low-risk surgery, you need to do nothing, not even an ECG. If they're going for an intermediate risk surgery, again, you do not need to do anything. Now, if they're going for a high-risk surgery, there's a class 2 recommendation that if they're above the age of 45, that it's reasonable to do an ECG and to do biomarkers. So the reason for that is adults above the age of 45, they're at risk of cardiovascular disease anyway, and the stress of the surgery can put them into stress. So this is mainly to catch post-operative MIs if they happen. So I'll explain to you later how biomarkers are done. Now, if we look, so there is one specific part of patients less than 65 that was not in the graph. So if the patient less than 65 has no symptoms, but has family history of genetic cardiomyopathy, this patient needs to be evaluated, even if they do not have symptoms. And we're not talking about someone who says, yes, someone from my family had an MI. No, this is just, expected. But if someone has ARVD, he had dilated cardiomyopathy at a young age in the family, then this patient needs an ECG and an echo before the surgery. Now, what about adults above the age of 65, or they have cardiovascular risk factors? Again, if they're going for a low-risk surgery, you don't need to do anything. Intermediate and high-risk surgery, you do need to do an ECG and biomarkers, and that's a class 1 indication. A class 2 indication is to assess the patient's functional capacity. That's usually done by history, so you try to establish how much metabolic equivalent the patient can do. So if they can climb 2 flights of stairs, then their functional capacity is good, and you do not need to go for any further testing. Now, if a patient has established coronary disease, and they're going for a low-risk surgery, again, nothing needs to be done. So look at all the low-risk surgeries, nothing needs to be done, not even an ECG. So imagine all the low-risk patients that you see for preoperative assessment. This was a huge waste of resource. And then if they're going for intermediate or high-risk surgery, then you have to do the ECG and biomarkers, and you have to do, and that's a class 2 recommendation to do functional assessment. Where does cardiology come in? And patients with cardiovascular disease who are going for high-risk surgery. So all the other cases, you're supposed to take care of it. So maybe you think, oh, the cardiologist took their hands off the situation, but it's not true, because all the times where we're measuring the biomarkers, how are we measuring them? So you're measuring high-sensitivity troponin before the surgery, and then 1 day after, and then 2 days after. So we're screening for silent MI. So all the patients who are going to have positive troponin afterwards, they're going to call us. So when I saw this and presented, I thought, oh my God, we're going to be very, very busy. Because there are many reasons to have postoperative troponins. It doesn't mean that they have an MI. But I think what the guidelines emphasize is that even if it is not an MI, these patients need to be evaluated, needs to be seen. So it's important to look for these situations. Okay. So this is all if the history and physical examination was normal, and I have 2 minutes left. So what about if it is abnormal? So if you have chest pain or new murmur or dyspnea or peripheral edema, if you have a new murmur and symptoms of cardiovascular disease, you need to do an echo. If you have a new murmur, no symptoms, but you have high-risk features from the examination, and that's the importance of examination. We all know aortic stenosis, you can tell if it's severe just by examining the patient. So if you find signs of severity on examination, then you need to do an echo. Now, if you find a new murmur, but no signs of severity and no symptoms, should you do an echo? They give it a lower recommendation, so they give it a class 2. But actually, if you read the text, they say all the studies showed that if you do these echoes, it's a complete lose of time. You're not going to benefit anything from doing these echoes. Of course, to convince the anesthetist to go for surgery, that's another story. But to be, scientifically correct, you do not need to do an echo in these situations. Now, if the patient has chest pain, then he has chest pain, So then you go through the algorithm that Dr. Abdullah Shahab showed you. You need to investigate this and look for the reason for this. So the first line, again, is about chest pain. Now, dyspnea and peripheral edema is a completely different story. Why? Because a lot of patients have dyspnea, and the guidelines recognize this. It doesn't have to be cardiac. So, of course, they tell you if you think it's cardiac, you need to investigate, but here comes the value of biomarkers. If you do a BNP on patients with dyspnea or low lymphedema and it's normal, this is not cardiac. And then you look for other reasons for dyspnea. It could be just reduced functional capacity. So biomarkers are key for any preoperative assessment. Okay, so I'm just going to skip some things. There are, these guidelines were done with a patient representative. So these are what the patients expect you to tell them. So they expect you to tell them what's going to happen to them, how they're going to take the medication, what problems can happen with surgery, who's going to contact the cardiologist if something happens. So this is something important to establish. So I think we'll stop over here, and we'll give some time for questions.